Thank you very much. Any questions from any of the members? Yes.
I do.
Madam Vice Chair.
Thank you, Mr. Chairman. For Ms. McLoy, you have two PowerPoint presentations that I'm very curious to understand a little more. Page 4, which you talked about 58% of your costs as labor costs. What does that compare to other states in the U.S.? Are we average? Are we above average? Or are we below average?
I think the U.S. average is somewhere between 50 and 55%. California does tend to be a little higher because of our higher cost labor markets, but it's very typical for hospitals nationwide to have over half of their costs attributed to labor.
Then my next question is, which you actually just kind of teed it up for me. Your page 5, you have the California hospital wages. You have the different counties. I'm so excited that Orange County, LA County is not always out expensive for everything, but I'm shocked because I would think that wages will be attributed to the living costs, housing and et cetera. And Sacramento it's quite cheap up here compared to housing down in Orange County. I'll tell you that. You can get something of $200,000-300,000 here, where that is not even available in Orange County for even a condo that I know of, even in my district, which is one of the poorest districts of Orange County. How did that happen? Well, I mean, these counties are much smaller in sizes compared to LA County and Los Angeles and Orange County, and yet your cost is outrageously more, or wages-wise. Did we negotiate worse over in Orange County, LA or something? I mean, I'm just, more curiosity than anything.
No, I think that's really good, and it's a really important point, just because, California, just by the nature of our geography, we are packed with microeconomies throughout the state. But what we find in Northern California is less prevalence of hospital beds, more prevalence of hospital beds, and more prevalence of skilled individual workers in Southern California. So it's a tighter labor market, which amplifies the shortage for many positions such as nurses, where there are mandated nurse staffing ratios. We have examples in the San Francisco area of brand new nurses out of nurse school entering the workforce earning more than a primary care physician, because that's what the market requires and that's what the demand is. And we find that demand more in Northern California than we do in Southern, because of the availability of workers and a few other indicators. So housing and having to live in Orange County versus others certainly is an element of it, but these come straight from the federal government themselves, and they measure the cost of hospital wages throughout the U.S., and it's all in Northern California, and primarily due to the shortage of and the premium that has to be paid to meet those staffing ratios.
So my takeaway from this, your presentation is that we in California need to do more in terms of building these skilled nurses or skilled workers, and to be able to put in the time and the effort for more individuals who want to go into those professions, so that not only can they continue to service Southern California, but we also should need to look at the northern part of California. That's what my takeaway is from your presentation in terms of wages then.
I think you're right. I think there are two takeaways. I think the takeaway you mentioned about making the pool of available workers more robust. I think the second thing that can be done immediately is California has unprecedented nurse staffing ratios that the rest of the nation does not have, and they're arbitrary. And if those staffing ratios were relaxed and in line with more national norms and averages, I think that would free up a large part of the workforce immediately.
Thank you.
You're welcome.
Let me just first start off by saying that I really appreciate it. I think one of the comments you made, and I'm not sure if it's correct, I just wrote it down, that the hospitals in California that are 8% below the national average, even though we have much higher labor costs and various segments. Did I get that one correct?
The 8% below the national average is the per capita spending, so it's all healthcare spending. Right. California is 8% below the national average, yes.
Okay, well I was very impressed with that, and I did hear loud and clear, it seemed like there was a universal theme to the cost drivers, which that's what we're looking for here, labor, obviously aging population. I totally agree with the government underfunding, especially with Medi-Cal, and the cost shifting to commercial and private pay, and that's definitely an inequity. Seismic state mandates, and of course, electronic health records. And I think there was one other one I forgot to write down. The
Staff ratios.
The staff ratios are the social issues that were there. But I have in the previous panels, it was brought up, and it's brought up on a regular basis. And let me just real quickly see if I can find my notes. That they're saying that when various entities are trying to negotiate rates, that they're finding that it's 30% higher in Northern California than Southern California. And in particular, I guess one of my question is addressed to Dr. Lockhart from Sutter, and especially in light of the most recent impasse, but unfortunately the negotiation with Blue Shield. Tell me and try to explain to me about market consolidation, and how does they justify the higher rates up north? And I can't imagine that it's all just strictly on labor cost, especially if there's much more competition in Southern California. So how do you answer that question?
Well, I might have to defer the issue of north to south to my colleague to the left, because Sutter Health facilities are all strictly in the northern part of California. But I will say that with respect to the market in the north, we do have a variety of providers that are available, and patients do have choice, which I think is an issue that has been raised. And certainly we know that, for example, during the Blue Shield issue, when we had to extend the time for patients to consider their options, the Department of Managed Healthcare actually noted that patients do have sufficient choice, as far as options for them to make. So I would note that I think that our patients in Northern California do have choice. I'm not sure I can comment on the comparative pricing of north to south. I don't know.
Well, I guess the reason why I ask is because it just seems to be an issue, and since I've been in the legislature, there always is a comparison to northern, especially when it comes to hospital systems, and the concern I'm getting is the market consolidation. But maybe you might be able to answer that or help out with that as well.
Absolutely, and I would refer back to the chart where I show the most expensive wage areas in the U.S. as published by the federal government. And of the top 11, the 10 are in Northern California. Number 11 is New York City, which is known for high wages alone. So the huge difference between the demand for wages down south and the demand for wages up north. And when you combine that with the fact that almost 60%, 58% of hospital spending is devoted towards labor, that is a major cost driver.
And I would note that despite those discrepancies, that if you look at the charges per discharge of Sutter Health, if you look at the overall California OSHPD data, we're a little bit below the median. So despite those geographic differences, we're working very hard to keep things under control to the best that we can.
In your recent dispute with Blue Shield, they claim that your hospital rates are 30% higher than the state average, and the OSHPD data indicates Sutter's operating profit margins is twice the average of California hospitals. How did you justify these excessive rates and margins?
Well, again, I would note that the rates that at least the Blue Shield had indicated to us, saying that our rates were at or below the median for many of the hospitals that are in our system. So I'm not sure how to otherwise, reconcile that, other than to note, as I said before, if you actually look at our rates with OSHPD, we are below the median. I think the median's around $40,000, and I'm sorry, 45, and we're at 40,000. So I'm not sure that that I can respond to the issue about being higher, because I think the data shows that we're not.
Okay. And then doesn't Sutter impose restrictions or notice requirements on when health plans can disclose costs and quality information about Sutter providers to enrollees? So question.
Restrictions? No.
Okay, seeing no other comments or questions from any of the members, thank you very much. I appreciate your time. We're going to move on to Item number 5, potential remedies. Meredith Shannon, MSHA Director, Market and Policy Monitor Program, California Healthcare Foundation.
Thank you.
Welcome.
Thank you. Thank you, Senator Hernandez, committee members. What I'd like to do is comment a little bit about some of the things that are in the healthcare system that end up driving some of these anomalies that people have talked about today. A system is usually perfectly designed to achieve the outcomes that it gets, and the healthcare system is no different. There are a number of factors about the healthcare system. It's, largely a factor of capitalism. You have people who are driven by incentives, and they try and maximize their incentives. And the healthcare system is a little bit unusual. I think capitalism depends on a well-functioning market, and healthcare has some anomalies that lead it not to be such a well-functioning market. So I want to just touch on a couple of those. The first is well known to this committee, the lack of usable price and quality information. So many people don't really know what things cost, and it makes it difficult for them to choose. Non-standard goods and services. All hospitals and physicians are not the same. It's not a fungible good. There are differences, and it's hard for people to discern those differences and understand what's of value and what's not. The huge asymmetry between what providers know and what patients know, and their patients' understanding of what their choices are. The inelastic demand curve, that there's really no relationship between price and the quantity demanded of the service. Highly variable competition between markets, and we've talked a little bit about that, the difference in Northern California and Southern California. And third-party payers that really distort the buyer and seller relationships. What we found, interestingly, we've covered California, is the concept of narrow networks. Those were developed by the health plans largely because they knew that when individuals were paying those premiums with their own dollars, they wanted value for that. They didn't necessarily have to have every hospital and every doctor in the network. They wanted something that was affordable to them. And the plans then, the narrow network products developed, and I think the very sort of intensive management of those plans as Covered California rolled out sort of shows that that was indeed what consumers wanted. There perhaps wasn't as much transparency about what consumers were buying as there should have been, but the design of the products was consistent with what consumers wanted. So we are beginning to see some signs of reform. We are seeing a slowing in costs, which is, I think, really important. And a lot of that is coming from the fact that the incentives are starting to change. So as I mentioned at the beginning, most providers respond to incentives. Now you have Medicare putting new rules in place, commercial payers that have become much more engaged and picking provider partners so that they can actually develop a cost-effective product in the market. But the issue, I believe, is one of transparency. So for us to know which of those reforms work and be able to understand how to control costs, we have to have a lot more information available and broadly available so that we can have sunshine on some of these transactions and really determine if they're in the public good or not. So there are three elements in particular that we might focus on. The first, meaningful price and quality information. As more and more patients are being moved into high deductible plans, they really do need to know what they're buying, and they need to know what they're buying before they're in the plan. So even though many health plans offer pricing tools for their individual plans, you don't know about those until you're a member. You're not able to use them until you're a member. So we need more information up front about which providers are in a network and what those providers cost all in. The second element that's really important is this issue of trade secrets. Often it comes up that pricing information for healthcare should be proprietary between plans and hospitals. There's a lot of evidence that disagrees with that, that we've seen some markets where there's been price transparency. New Hampshire is sort of the classic example. They've had true price transparency for about 6 years, and it actually has helped in disputes between hospitals and health plans to have some transparency about where is the value there and which side, is essentially right. What are the facts? Having true transparency allows you to see those facts. And the last piece is we really need to understand some of these new models and these new systems. And without transparency, it's really difficult to see what's going on. We may get reports from individuals. CalPERS, for example, had mentioned this morning they've had a lot of success with their integrated system, which is great, but that's just using their design and their information. It'd be helpful to be able to look at all of these different models that are going on and be able to compare them across. So I think transparency is really going to help us look at which payment reforms are the most effective. So all of these factors really, the price transparency, the available quality information, as well as being able to evaluate new models, all really pivot off of transparency and accountability in the healthcare system, because that's really the only way we're going to know what we're buying, what we're paying for, and whether it's of value. So I'll just stop there for questions.
Thank you. Any questions? Seeing none. Seemed like this is the second time we've had a hearing on cost drivers, and there's an overriding theme of transparency. Talk to me a little bit about your number 2 point, the trade secrets, and I mean, who is that? Is that hospital systems? Is it medical groups when they're negotiating contracts? And how do you see that benefiting the consumer if we were to have that transparent?
Yeah, there's actually a lot of debate on this right now, but increasingly the research is showing that proprietary prices is not in the public interest, that it leads to higher prices, not necessarily lower prices. There's a little bit of there are some concerns from the Federal Trade Commission about how prices are actually displayed to prevent price transparency from becoming a problem. So being able to release episodes of care for whole treatment, that's both more useful for an individual patient, because you don't want to have to get the hospital charge and the physician charge and the anesthesiologist charge and have to add it together. You really want to know, I'm going in for this particular condition, I'd like all in to know what the price is with this system in this network that I've chosen. That's not in violation of any FTC rules about price transparency that could be anti-competitive. So there are a number of things that we can do that would allow people to have information about price that would not fuel anti-competitive practices.
So what do you think has caused that culture that we have in this country with regard to healthcare? Is it just the nature of how we provided the care? I mean, because I couldn't even imagine the consumer now ever wanting or going to buy a car and just going to the first dealership and just say, okay, I'll settle for that price without internet, online, you know, and price shopping. So why our healthcare system is different?
I think it's because some of those elements I mentioned in the healthcare system, that you've got these third-party transactions. It's actually the insurance company who's paying and has information. And so consumers really aren't in the position they are for most other goods and services, where they have information, they can research it. And this issue of information asymmetry, it's really hard for a lot of patients to understand medical jargon and issues and really know what they're buying. So they rely on their physicians to do that interpretation for them. And that asymmetry itself doesn't make for a very transparent and well-functioning market.
Okay, thank you. Seeing no other questions, comments, thank you very much for your time. We're going to move on to item number 6, public comment. We can have individuals who, they can just come up here and speak right there is fine, or wherever you want.
Beth Capella on behalf of Health Access California. Just to note that while it's been a useful hearing and interesting today, we are disappointed by the lack of consumer advocate participation in the efforts today. We do respect the labor folks who testified on behalf of their own members and CalPERS, which certainly takes very good care of its own members, but we would hope that in the future we would not see a hearing without consumer participation.
And that's, you know, part of the discussion. This is, like I said, one of several and many hearings we're going to have, and well noted, and thank you very much. Anyone else? Public comment?
My name is Tom Stevens, and I guess I could say I've actually lived this whole session that you've been talking about. I got hepatitis C 36 years ago from a blood transfusion, and I just finished up with Harvoni, their treatment, and the viral load is now 0, so I'm cured. But in the meantime, you're concerned about cost care. This healthcare system has spent a small fortune treating me for all kinds of other treatments that were just related to the hep C. And so how do you justify, where do you ever put a value on that? So that's the problem, is if you say, well, the drug is $100,000, but how much money did you waste doing all these other things to people that were just a total waste of time. So that's, I've lived it.
Thank you. I
Okay.
appreciate it. Thanks for coming up.
Okay.
Anyone else? Any other public comment? Seeing no public comment, I'd like to just take this opportunity to thank all those individuals who were participated in the panel. Appreciate your time, and with that, we will adjourn today's hearing.